timekeeping here. I'll try to get 8 minutes. All right, so myocardial perfusion imaging is, of course, a powerful tool for diagnosing coronary artery disease by looking at the downstream effect of myocardial ischemia. It's done by performing dynamic imaging of the first pass of a gadolinium contrast agent. And the delta R1 changes with proportion to contrast agent concentration, and it can be used to quantify myocardial blood flow. The technical challenge with this is that there's so many things going on in the heart all at once, of course. There's cardiac motion, respiratory motion. Typically, these are saturation recovery sequences, so there's T1 recovery occurring, and of course, the dynamic contrast enhancement that we care about. And these all overlap and are occurring simultaneously. The standard way of doing this imaging is to freeze the dynamics that we don't care about. So we can synchronize our imaging with ECG to get rid of the appearance of cardiac motion. We can ask the patient to hold their breath, get rid of respiratory motion, pick one saturation time per slice, typically. That gets rid of the appearance of T1 recovery, and we're left with the dynamic contrast enhancement that we want to quantify. Of course, this comes with very familiar issues. ECG triggering may skip or misfire. Breath holds are difficult for many patients. The slices end up having different T1 weightings and actually show different cardiac phases. And then the blood signal saturates for a single T1 weighting, obscuring peak contrast. And so there's two basically frameworks for dealing with that. One is a dual bolus, and one is a dual sequence method. So our approach to this is actually by doing multidimensional imaging, which instead of freezing those dynamics actually embraces all of them, assigning each one its own time dimension. So this means that there's not going to be a need for an ECG signal. We're going to get images at every cardiac phase. The patient can breathe freely. We're going to actually collect multiple T1 weightings, which means we can do R1 mapping and use this for quantification. And then what we're actually going to be doing with all this is resolving all these multiple overlapping processes. So this is a growing trend, this multidimensional imaging in CMR, including, as we saw in the first talk, HD Prost. And our version of this is multitasking, which is a low-rank tensor imaging. And basically what it does is it scales really, really well, even with many dimensions. So typically you would have the cursor dimensionality where your scan time and memory are going to grow exponentially with the number of dimensions. With myocardial perfusion, you really only have about maybe 60 seconds, so that can be quite a problem. Whereas a low-rank tensor actually grows approximately linearly. So this becomes a very powerful tool for doing fast multidimensional imaging. There's a particular challenge for multidimensional imaging when we're doing DCE, which is that the contrast dynamics are transient. They do not repeat and cycle. And so this means that we can be particularly problematic if we have irregular breathing, not so much cardiac because it's happening at a different time scale. But what it means is that the actual respiratory pattern that we can see here is our sampling pattern in the respiratory DCE space. So if there's any irregularity in how deep the patient is breathing, we can get very unfavorable sampling patterns. And so our approach is to actually combine the DCE and respiration as opposed to separate dimensions, go with a partially multidimensional approach. And so we have a respiratory motion compensated DCE dimension, essentially. And I'll show what that means a little clearer in a bit. And the respiratory motion compensation has been shown to allow a sparser representation for respiratory resolved CMRA and has been shown to benefit low-rank matrix myocardial perfusion in the past. So our pulse sequence here is a continuous acquisition SR prepared flash sequence. Basically, we have in between our SR pulses every 300 milliseconds or so, it's completely filled with flash readouts. We have a 3D stack of stars trajectory with golden angle angular ordering in plane and a random Gaussian partition ordering. And we're going to collect some training data every 4 readouts, and this is the 0-degree spoke at the center partition. We did some experiments on a 3T Siemens biograph MMR in n equals 10 healthy subjects at rest. Basically 2 by 2 by 8 millimeter spatial resolution, 20 cardiac phases. We ended up with 88 saturation times for T1 mapping. We administered a 0.05 millimole per kilogram dose of gadabutrol at 4 milliliters per second. We did our MBF myocardial blood flow quantification by Fermi deconvolution of our delta R1 after mapping. And we also collected a 3-slice dual bolus reference 20 minutes prior to the multitasking. So the image reconstruction occurs in a few steps. The first step is to get 3D image navigators. And so what we have here is we're doing a low-rank matrix imaging just to get all the images that are all the different dynamics actually still mixed together at this point. So you can see respiration, cardiac motion, DCE, as well as a T1 recovery. That's this strobing effect that we're seeing here. And we extract systolic cardiac phases here at the latest possible saturation recovery within each heartbeat, and then use a mutual information cost function to handle the fact that there's a little bit of variable T1 weighting in here and the different DCE phases, and then just perform 3D translational registration focused over a region in the heart. So then we directly, by the way, we also directly compensate our K-space. So the remaining steps of image reconstruction, I'll skip the gory details here, but basically we take that training data that we collected every 4 readouts, we build a subject-specific temporal model, and then this gives us a feature space that we can find our image within that using the rest of the data. So before I show the rest of the results, I just want to show the effect of the respiratory motion compensation. If we just do a mix of respiratory DCE time dimension here, you can see that there's quite a lot of blurring that happens. There's this respiration that's confounding the effect. And if we actually use just the simple translational motion compensation, a lot of this respiratory motion is reduced, at least over the cardiac region. And here's a couple frames here. You can see just how much blurring is fixed by doing the respiratory motion compensation. Here's some example images. So this is one subject. This is first looking at systole. So you can see here that we have quite large spatial coverage, not just the multiple short axis slices, but we can actually look at the long axis views. If we look at just the DCE, which is this temporal profile on the left, the effect of respiration is very, very low. And of course, as I mentioned before, it's cardiac resolved, so we could also do our analysis at diastole if we preferred. And here's some actual movies from a different subject showing it both systole and diastole for different views here, actually watching the perfusion process occur. So since we're doing, as I mentioned, R1-based quantification, we can get our quantitative maps and actually quantify myocardial blood flow from just this single bolus. And so here's an example for this subject of the bullseye plot. Over all subjects, we calculated an average of 0.8 milliliter per gram per minute. The dual bolus had 0.6 milliliter per gram per minute. So actually, we have a significantly higher estimation here, but both still in the normal range at rest. So in conclusion, 6D multitasking is feasible for quantitative myocardial perfusion imaging with 3D acquisition, no breath holds, no ECG, multiple cardiac phases, a single contrast bolus. Respiratory motion compensation improves image quality, and we observed myocardial blood flows in healthy subjects at rest, all in the published normal range. So the next step, of course, is a thorough validation of this in rest and stress against either dual bolus or against simultaneous PET on a PET-MR scanner, as well as validation in patient population. Obviously, there's not a whole lot to see normal at rest. So with that, I'd like to acknowledge all my colleagues at the Cedars-Sinai Biomedical Imaging Research Institute. Thank you very much.